Hi everyone, this is Miss Sheridan from Georgia Northwestern Technical College, Floyd County campus, and I'm going to be doing your lecture today on Chapter 11, Nursing Care of Patients with Cancer. These are your learning outcomes for Chapter 11, and it's a great idea when you're studying these chapters that you use these learning outcomes as a study tool. So you can actually go in and kind of quiz yourself. Can I answer each of these different learning outcomes just to assess whether you fully understand? So your learning outcomes are listed on page 142 of your text. Just make sure you familiarize yourself with those. So first, your book talks about just a normal anatomy and physiology regarding normal cells. Cells are the smallest living structure and functional subunits of the body. Although human cells vary in size, shape, and certain metabolic activities, they have many different characteristics in common. The genetic code of DNA is the code for the amino acid sequences needed to synthesize a cell's protein. In other words, the genetic code are like the instructions, the roadmap that tells the cell how to make a specific protein. So if at any point there's a mistake in that DNA genetic code, if there is a mistake in those instructions and that roadmap, that process of protein synthesis continues on, but the resulting protein does not function as normal. So those are called genetic mistakes, called mutations. These mutated, altered cells have the potential to become malignant. Cancer is a group of cells that grow out of control. They take over the function of that affected organ. Cancer cells are known as being very poorly constructed, very disorganized. We call them a confused cell. So cancer begins in cells. Your cells are your building blocks that form tissues. Tissues make up organs of the body. So normally, cells grow and divide to form new cells as the body needs them. When the cell grows old, they die off and then new cells take their place. However, sometimes, as with cancer, this orderly process goes wrong. There's some genetic mutations that occur and new cells form sometimes when the body does not need them. And old cells sometimes do not die when they should. So those extra cells can form a massive tissue that we call a growth or a tumor. A cancerous growth is very difficult to detect until it contains about 500 cells and it's approximately 1 centimeter in size. So some cancer growths are not cancerous, we call those benign. And some others are cancerous. Those are malignant, and we will discuss each of those in detail in this slideshow. A neoplasm is a term referring to tumors, a new abnormal tissue growth. A benign tumor are rarely life-threatening. They are non-cancerous. They are a cluster of cells that are not normal to the body, but they are non-cancerous. Benign tumors grow more slowly than your malignant ones, and benign tumors have cells that are the same type as the original tissue. So if you have a benign tumor, let's say of the lung, for example, if you were to biopsy that site, it would have lung cells in it, so it tells you where it's originating from. Generally, benign tumors can be removed, and usually they do not grow back. Cells from benign tumors do not invade the tissues around them. They do not spread or metastasize. Malignant tumors are tumors that are cancerous. They are generally more serious than benign tumors. They may be life-threatening. Sometimes malignant tumors can be removed or excised, but sometimes they're known to grow back. Cells from malignant tumors can invade and damage nearby tissues and organs. Cells from malignant tumors can spread or metastasize to other parts of the body. Cancer cells spread by breaking away from the original or primary tumor site, and they enter the bloodstream or the lymphatic system. That's the means they're using to spread themselves. The cells then invade other organs and form new tumors, and those tumors can damage those organs. So the spread of cancer is called metastasis. So a malignant tumor is cancerous. It's often resisting treatment and tends to worsen and threaten life. So cancer is a group of cells that grow out of control. Eventually, they take over the function of the affected organ. Cancer cells are poorly constructed, disorganized, and very fast growing. So there's a mutation that's occurring there of those cellular genes with abnormal cell growth. Cancer is not one disease, but it's many different diseases with different causes, treatments, prognoses. There are more than 100 types of cancer. Normal cells are limited to about 50 to 60 divisions before they die off, but cancer cells do not have a division limit. They are considered immortal, if you will. They continue to grow out of control until they're destroyed. Cell mutation occurs when an alteration affects the chromosomes, and it causes the new cell to differ from its parent cell. The malignant cell's enzymes destroy the glue-like substance found between the normal cells, so this disrupts the transfer of information and communication used for normal cell structure and growth. Cancer cells also lack contact inhibition, and that's a term we need to be familiar with, contact inhibition. And that is the growth regulating signals in the cells. And cancer cells lack contact inhibition, meaning they don't know when to stop. They just keep on growing and growing, and they continue to divide and invade surrounding tissues. They're not following the signals telling them to stop. So if you think of it like subway commuters on a crowded train, the cells generally prefer not to be packed in too tightly. So they've set up mechanisms to avoid this. This is a phenomenon called contact inhibition. A hallmark of cancer cells, malignant cancer cells, is that they lack this contact inhibition, and instead they become pushy. They facilitate their spread instead of stopping. Healthy cells and developing organs just know when they should grow and when they should stop growing based upon these signaling contact inhibition. However, cancer cells do not know when to stop. This is a great table in your book on page 146, and they compare benign and malignant tumors. So your benign tumors are slower to expand. Your malignant tumors are rapidly growing, and they often infiltrate your surrounding tissues. Your cell features of your benign tumors, like let's say we were to take a biopsy, a sample of those cells, and look at it under the microscope, your benign tumors would have cell features that are typical of the tissue of origin. So, for example, if it's like a tumor on the prostate, it's going to have prostate cells. Your malignant tumors are atypical compared with the tissue of origin. They also may contain tumor-specific antigens, like how with prostate cancer, you have elevated prostate-specific antigen. And that's mentioned later on in this slide, and it's also in our reproductive chapters as well during this module. So when cancer spreads, the malignant cancer is spreading, we're forming a new tumor in another part of the body. The new tumor has the same kind of abnormal cells and the same name as the primary tumor. So for example, if prostate cancer spreads to the bones, the cancer cells in the bones are actually prostate cancer cells. So doctors can use that to see where the cancer first originated from. So the disease in that example I just gave is metastatic prostate cancer rather than bone cancer. So for that reason, it's going to be treated as prostate cancer, not bone cancer. So benign tumors have typical cell features of the tissue of origin. Malignant ones can differ. It's atypical. Tissue damage with benign tumors is minor, whereas malignant is known to cause necrosis and ulceration of tissues. Metastasis, or the spread, that is not seen with your benign tumors. It's localized. It stays in one place. Your malignant tumors, however, spread and they form tumors in other areas of the body. Your benign tumors seldom reoccur after they're surgically removed. It's called an excision. Malignant tumor, however, are more prone to reoccur even after surgical removal and following radiation and chemo. So your prognosis for benign tumors are pretty good for your benign tumors. They don't cause injury unless the location causes pressure or an obstruction to the vital organs. Malignant tumors have a poorer prognosis. It could cause death if uncontrolled, depending on the severity. The etiology, or the cause of cancer. Cancer cell growth and reproduction involve a three-step process, and that is initiation, promotion, and progression. Your first step, initiation, is the result of an alteration in the genetic structure of the cell, the DNA. So you have that mutation occurring. This either occurs spontaneously, so without a cause, it just happens, or it can follow exposure to a carcinogen. So your carcinogen is a substance or an agent that increases the risk of cancer. such as asbestos or tobacco smoke, making somebody prone to lung cancer. So that cellular change, that mutation, primes the cell to become cancerous. Your second step in cancer growth is promotion. This occurs after repeated exposure to carcinogens that causes the initiated cells to mutate. So the tumor forms from the mutated cell reproduction. During the third step, progression, it further mutates. So further genetic mutations occur, leading to growth and metastasis or spread. A healthy immune system can often destroy cancer cells before they replicate and become a tumor. It's important to remember that any substance that weakens or alters the immune system is going to put the individual at risk for cell mutation with the potential to develop into cancer. Risk factors for cancer. So the first one is oncoviruses. These are certain viruses that are linked to cancer in humans. These oncoviruses insert their own RNA into the host cell, and they cause a mutation with the ability to produce a cancer. A good example of an oncovirus is the herpes simplex virus type 2. That's associated with cervical and penile cancers. Also the human papillomavirus, or HPV. That's associated with cervical and vaginal cancer in women, penile cancer in men, and cancer of the anus, and some head and neck cancers in both sexes. So they have a vaccination against HPV called Gardasil that's recommended for girls and boys aged 11 to 12. Another example of an oncovirus is your chronic hepatitis B that is linked with liver cancer. Radiation is also another risk factor for cancer. An increased incidence of cancer occurs in persons exposed to prolonged or large amounts of radiation. Ionizing radiation involving ultraviolet rays like sunlight, X-rays, plays a major role in promoting leukemia and skin cancers, primarily melanomas. Persons exposed to radioactive materials in very large doses like a radiation leak or an atomic bomb are at risk for leukemia and breast, bone, lung, and thyroid cancer. They do use controlled radiation therapy to treat cancer patients by destroying rapidly dividing cancer cells. But radiation can also damage normal cells. So you have to, as a doctor, they have to carefully decide to use radiation after they evaluate the tumor's location and the vulnerability to the radiation treatments or the other treatments. Chemicals are also a risk factor. These chemicals are present in air, water, soil, food, drugs, and tobacco smoke. Chemical carcinogens are indicated as triggering mechanisms in creating these malignant tumor development. The length of time and degree of exposure to this chemical carcinogen are associated with risk for cancer. So a good example of a chemical risk factor is tobacco smoke and alcohol. Irritants, so chronic irritation or inflammation caused by irritants like snuff or pipe smoke are often cause cancer in localized areas like the throat. Nevi or moles that are chronically irritated by clothing especially clothing contaminated by a chemical residue, can become malignant. Asbestos found in temperature and sound insulation has been proven to cause a particularly destructive type of lung cancer. Genetics also play a huge role in cancer formation. So there's certain breast cancers that are linked to a specific gene mutation that you could get tested for if you know you have a positive family history for breast cancer. Skin, colon, ovarian, and prostate cancers have a genetic tendency. People with Down syndrome have a higher risk of developing acute leukemia. Diet is also a major factor in the cause and the prevention of cancer malignancies. People who eat a high-fat, low-fiber diet are more prone to develop colon cancer. High-fat diets are also linked to breast cancer in women and prostate cancer in men. Consumption of large amounts of pickled, smoked, and charbroiled foods has been linked with esophageal and stomach cancers. A diet low in vitamins A, C, and E is associated with cancers of the lung, esophagus, mouth, larynx, cervix, and the breast. Hormones. So hormonal agents that disturb the body's balance can also promote cancer. Long-term use of the female hormone estrogen, like estrogen replacement therapy, for example, is associated with cancer of the breast, uterus, ovaries, cervix, and vagina, all your female cancers. Immune factors. So an individual with an impaired immunity, they're immunocompromised, they're going to be more susceptible to cancer formation when exposed to small amounts of carcinogens compared with someone with a healthy immune system. So for example, people with AIDS have an increased cancer risk because they are immunocompromised. People on medication that reduces the immune function are also at risk. A decline in the immune system and an increase in cancer risk are also noted just due to the aging process as the body ages. The highest incidence of cancer in women is breast cancer. So you can see that right here, breast cancer in women. In males, your highest incidence of cancer is prostate cancer. One thing I want you to note is that even though prostate and breast cancer are more prevalent in males versus females, lung cancer has the highest mortality rate among both men and women. Lung cancer. See, this is estimated deaths up here, whereas this is estimated new cases. So as far as which type of cancer has the most deaths associated with it, it is lung cancer in males and females. In your males with this high incidence of prostate cancer, they are at an increased risk for this between the ages of 60 to 79, and they do this test called the prostate-specific antigen, the PSA, and that is a tumor marker. So when your PSA is elevated, it's showing that they have prostate cancer or they likely have prostate cancer. So even though prostate cancer is more common in men and breast cancer is more common in women, The one with the worst prognosis is your lung cancer. Now, with the women talking about breast cancer, this is going to be important. The hypercalcemia that often occurs with breast cancer. Hypercalcemia is often linked to metastasis of cancers. When cancers spread to the bones start breaking down, and calcium's a big component of our bones. So when the bones break down, that calcium moves into the bloodstream. So it causes hypercalcemia, an elevated calcium level in the blood. And that is due from bone deterioration due to the metastasis. This table outlines the different types of tumors and which ones are benign versus which ones are malignant or cancerous. You can also see this in your book, Table 11.2 on page 148. That's page 148. So, an osteoma, and if you're good at word building, you can kind of break down the word and figure out where the origin is. Osteoma is a benign tumor type. It is non-cancerous, and it is an overgrowth of pre-existing bone. Adenoma is a benign tumor type as well, and that is of the epithelial tissue with a glandular origin. When they talk about epithelial tissue, they're referring to the thin layer of tissue covering the organs, glands, and other structures. A common type of an adenoma is a polyp in the colon, for example. A fibroma is a benign tumor type. This is of the fibrous connective tissues. Think of connective tissues as fibers, very fibrous. A lipoma is a benign tumor type of the fatty tissue. Think liposuction. So it's a benign tumor of the fatty tissue. Everything from here on down is malignant in tumor type. So everything from there down is malignant. And the first one is sarcoma. It is a malignant tumor. Origin is connective tissue, including our bone and our muscles. Sarcoma, carcinoma. I just remember the ones that contain AR, they are malignant. They are cancerous. Sarcoma is also malignant, and that is the origin of the skin, glands, digestive tract, urinary tract, and respiratory tract lining. Leukemia, this is also a malignant cancer of the blood, plasma cells, and bone marrow. Lymphoma, this is malignant as well of the lymph tissue. Melanoma, of course, is a malignant skin cancer. Its origin is the skin cells. In situ tumors. In situ, this refers to neoplastic or cancer cells that remain in one area. They are localized. So they are not invading any other tissues beyond their origin site. It literally means in Latin, in position or on site. My memory jogger that I use for in situ tumors is they sit in one place. In situ, it has the word sit in it. Sit in one place. They are not moving. They're not spreading. So metastasis is the spread of the tumor from the primary site into separate and distinct areas of the body. There are 3 steps in the formation of metastasis. So these are the different routes that cancer can use to spread. They can invade the blood or the lymph vessels. The circulatory system, the blood, is the primary route of spread to distant organs, while lymphatic vessels provide a route to local lymph nodes, after which metastasis often travels throughout the blood. Cancer can also move by mechanical means, or it can dislodge and grow into a new location. Cancer cells are much more fragile than your normal healthy cells, and they survive for a time independently from other cells. Metastatic tumors carry with them the cell characteristics of the original tumor site. So that is how the surgeons can determine the original tumor based on the cell characteristics. For example, lung tissue found in the brain suggests a primary lung tumor with metastasis to the brain tissue. Common sites of metastasis are the lungs, liver, bones, and brain. So prevention is key, and as nurses, we play an important role in preventing and detecting cancer. We do that by educating our patients about risk factors, self-examination like a breast self-exam, genetic testing, and cancer screening programs. Early diagnosis and treatment are very important in fighting cancer. Regular physical exams help healthcare providers detect early warning signs of cancer. The American Cancer Society recommends a mammogram, which is a special X-ray of the breast, to detect a mass that's too small for palpating. They recommend a mammogram every 1 to 2 years in women after age 45. Screening should then continue as long as the woman is in good health and they have a life expectancy of 10 years or more. Initial Pap testing for cervical cancer is recommended to begin no later than age 21 and be performed every 3 years up to age 29. The preferred approach for women aged 30 to 65 is to have a Pap smear with an HPV test, a human papillomavirus test, every 5 years. Some women continue to choose not to be screened even when they have access to health care, and a lot of those barriers have to do with being fearful. And being fearful of the testing procedures or the healthcare personnel or lack of knowledge. Women who fear cancer but trust their healthcare providers and seek information are more likely to be screened. So as a nurse, you can help by developing that trusting relationship, that rapport with your patients, and providing information to your female patients. The American Cancer Society considers the monthly breast self-exam that you do at home to be optional for women and testicular self-exam to be optional for men. Although it's good to do it. They say it's optional now, but you're better safe than sorry. They encourage everyone to be familiar with their bodies and to report even the slightest changes to their healthcare providers. The American Cancer Society recommends one of the following to screen for colorectal cancer beginning at age 50. like a flexible sigmoidoscopy every 5 years or a colonoscopy every 10 years. They recommend a fecal occult blood test every year, stool DNA test every 3 years. You can see all these on page 149 to 150. Promotion of healthy lifestyles, including proper diet and exercise, helps strengthen the immune system and reduces cancer risk. Smoking is the most preventable cause of death from lung cancer. Also, protectant food. They say folate and fiber and low saturated fat are all good ways to reduce your risk factors for cancer. GI cancers are linked to large consumption of pickled, smoked, and charboiled foods. Colon cancers are linked to high fat or low fiber diet. Your breast and prostate cancers are linked to high fat diets. And you want to limit alcohol as well, since that is a risk factor for cancer development. Diagnosis of cancer. Accurate identification of cancer can be made only by biopsy. We will discuss the different types of biopsies on the next slide, so we'll talk about that in just a minute. Laboratory tests. So blood, serum, and urine tests are very important in establishing a baseline and getting insight to the health status of the individual. An elevated white blood cell count is expected if the patient has evidence of infection. However, if you see an increase in white blood cells without any evidence of infection, that raises suspicion of leukemia. Bone marrow aspiration is done to learn the number, size, and shape of red blood cells, white blood cells, and platelets. That's a major tool used to diagnose leukemia. Tumor markers, also called biochemical markers, are proteins, antigens, genes, hormones, and enzymes produced and secreted by the tumor cells. An example is prostate-specific antigen, your PSA, for prostate cancer. So if your PSA is elevated, it's signifying prostate cancer. Or carcinoembryonic antigen, your CEA, that is linked to colon and rectal cancers. Those are in table 11.3 for you on page 153. Cytological studies are the studies of the formation, structure, and function of cells. This is obtained mainly through smears of cells shed from a mucous membrane, Test results are based on the degree of cell abnormality. So like a pap smear, for example, that would be an example of a cytological study. There's also nuclear medicine imaging. So this is camera imaging of organs or tissues containing radioactive media, such as a PET scan that provides information about cellular function. The patients are given biochemical compounds and then images are made of the tissue through gamma camera tomography. So these PET scans are useful in detecting things like brain cancer, cancer of the lung, ovaries, colon, rectum, and breast. Ultrasound procedures. So ultrasounds help detect tumors of the pelvis and the breast. They can also help distinguish between benign and malignant breast tumors. Magnetic resonance imaging and MRI is valuable in the detection, localization, and staging of malignant tumors in the central nervous system. Also the spine, head, breast, and musculoskeletal system. Endoscopic procedures detect visualization of the body cavity or opening. Endoscopy enables the surgeon to biopsy the tissue, like a colonoscopy, for example, when they take biopsies. It is used to detect lesions of the throat, esophagus, stomach, colon, and the lungs. A fine needle aspiration biopsy. So this involves inserting a needle into the tissue, and they aspirate out fluid or tissue, and then they analyze it underneath a microscope. So it's done for diagnostic purposes to see the cell characteristics, and an incision is not made here with the fine needle biopsy, so that is one of the advantages. Microscopic examination of the sample of suspected tissue or aspirated body fluid can confirm the presence of abnormal or cancerous cells. Your biopsy could be done in the healthcare provider's office, the outpatient surgery department, or the hospital. A stereotactic biopsy. This uses computer imaging, such as a mammogram, to help visualize, so that it helps guide the removal of tissue for examination by a pathologist under a microscope. So they're using that computer and imaging to localize the target lesion, such as a tumor in the breast. A mammogram. So a mammogram is an X-ray image of your breast used to screen for breast cancer. They play a key role in early breast cancer detection, and they help decrease breast cancer deaths. How staging is determined. So tumor staging helps to describe the extent of the cancer, and it helps to have a lot of insight into the development of the treatment plan. The most common system they use to stage tumors are called the TNM staging system, and it stands for tumor node metastasis, TNM. The T refers to the size and extent of the main tumor. The main tumor is normally called the primary tumor. N refers to the number of nearby lymph nodes that have cancer. And the M refers to whether the cancer has metastasized. Another therapeutic intervention for cancer includes surgery, and there are three main types of surgery. You have prophylactic, which means preventative. That's used to remove moles or lesions that have the potential to become malignant. An example of a prophylactic surgery might be your colon polyps that are often removed to prevent malignancies from developing. Or you go to a dermatologist and they remove a mole because it has the potential to become malignant. Another type is palliative surgery. So palliative surgery is all about symptom control, making the patient as comfortable as possible. The goal is to increase the comfort and the quality of life for the patient, but it is not to cure the patient. It will not cure them of cancer, but it will make them have less pain and discomfort. They're going to be more comfortable. For example, if the patient is towards the end of life and they have a very large tumor, so large that it is compressing on the nerve endings, Those nerve endings, when they become compressed, cause a lot of pain and discomfort for that patient. So the surgeon may go in and excise or cut out that large tumor just to relieve some of that pressure on those nerves, therefore decreasing the pain and making the patient more comfortable. Although they know it's not going to cure that patient's cancer, the overall goal for that surgery is palliative in nature, symptom control, making them comfortable. You also have reconstructive surgery, so that is cosmetic enhancement or for the return of a function of a body part. An example might be a breast reconstruction after a mastectomy. Radiation therapy kills cancer cells or slows their growth by damaging the cancer cell's DNA. Cancer cells whose DNA is damaged beyond repair stop dividing or die. When the damaged cells die, they are broken down and removed by the body. Radiation therapy does not kill cancer cells right away. It takes days or weeks of treatment before the DNA is damaged enough for the cancer cells to die. Cancer cells keep dying for a period of weeks to months, depending after radiation therapy ends. Radiation can be used as curative treatment if the cancer is localized. So radiation is used when the cancer is localized. Radiation destroys cancer cells by affecting cell structure and the cell environment. The decision to use radiation is based on the site of cancer and the size. Treatments use special equipment to send radiation to break up the cancer cells locally, causing little systemic or body system-wide effect. However, there's some side effects that can occur in the area being treated because of the damage to normal cells. So radiation not only kills cancer cells, but it can also damage normal healthy cells as well, just like chemotherapy. Radiation can also be used before surgery to decrease the size of a large tumor. So radiation can help shrink the large tumor so that when it comes surgery day, the surgeon is more prone to be able to get the entire tumor. It makes the surgery more effective and less dangerous. It can also be used after surgery. Palliative radiation is also used to reduce the size of a large cancerous lesion. So it helps shrink the tumor or the lesion so that it's not compressing on those nerves quite as much, helping to relieve some pain. Side effects of radiation. So symptoms of tissue reaction to radiation can be expected about 10 to 14 days after the radiation treatment starts. Symptoms can continue for up to 2 to 4 weeks until after the radiation treatment ends. Typical actions and appropriate nursing interventions include the following. So our first side effect is fatigue. We need to encourage frequent rest breaks and naps. Reassure the patient that the fatigue will subside after the treatments are completed. Nausea, vomiting, and anorexia. And when they're talking about anorexia as a side effect, they're talking about a very severely decreased appetite. So some patient education or nursing interventions that we can do to help with these side effects are to encourage our patients to take our meds prescribed for nausea and vomiting, our antiemetic meds. Add nutmeg to foods. Nutmeg has an antiemetic quality to it. Provide oral care before meals. Offer sour foods containing lemons to help with nausea. Anorexia can be eased by providing small amounts of high-carb, high-protein foods and avoiding foods high in fiber. So you want to avoid giving them a very large meal at one time. Instead, provide them small, frequent meals, high carb, high protein. Avoid foods high in fiber because a lot of times fiber can kind of induce nausea. Mucositis. So this is an inflammation of the mucous membranes, particularly of the mouth and the throat. So this is very commonly seen after radiation. Remember that radiation not only attacks cancer cells, but all rapidly dividing cells, such as the cells of the mouth and the throat here, how they're starting to break down and inflame. You can see mouth ulcers and things like that. Teach your patients to avoid irritants like smoking, alcohol, acidic food or drinks like orange juice, for example, very hot or cold food or drinks. Provide mouth care. And I would follow your facility protocol for mouth care. You know, they're saying every 3 to 4 hours. In some places, it's every 2 hours. Always follow your facility policy. Provide mouth care before meals and use a neutral mouthwash. Neutral meaning no sort of alcohol or irritant in that mouthwash, like Listerine is too harsh. You need something very mild. You can give them a neutral mouthwash made by using 1 ounce of Benadryl, liquid Benadryl, elixir diluted in 1 quart water or normal saline solution. And then you add an agent that coats the mouth like calcium carbonate or Maalox. So a lot of times your pharmacy, if the doctor orders this, they'll mix it up right there for you. So it's liquid Benadryl mixed with either water or normal saline and Maalox. Sometimes they will add lidocaine to it as an, numbing effect to it. These are some more side effects of radiation. Make sure you familiarize yourself with all these terms. You may see them again. The first one is xerostomia, and it means dry mouth. So things we can do to help that is to encourage frequent oral care, over-the-counter saliva substitute, it's helpful, especially at night, that saliva substitute when patients describe a choking sensation from extreme dryness. Skin reactions. This is called desquamation, peeling skin. So keep the skin dry, free from irritants such as powder, lotions with fragrance, deodorants, restrictive clothing. Avoid direct sunlight. Wash with a very mild soap and water. Rinse and pat dry. Irritated skin can be very fragile during treatment. It's important to wash those areas very gently. Avoid, rubbing them just briskly. You want to be very gentle with mild soap and water. Rinse well and pat dry. And take note also that the skin may have markings or tattoos to delineate the treatment field. Take care not to wash off those markings. Bone marrow depression. This is a biggie. And we'll talk about this again when we get to the side effects of chemo. Bone marrow depression are low blood cell counts that occur with both radiation and chemo because radiation and chemo attack all rapidly dividing cells, not just cancer cells. So they're also attacking our blood cells. We want to teach our patients to comply with weekly CBC checks. They need to check levels of their white blood cells, their red blood cells, and platelets. They may need blood transfusions, and it could be of whole blood, platelets, or blood components based on the lab levels, just per the MD discretion. And we will talk about some medications that are used to stimulate production of blood cells in this slideshow as well. Radiation may be administered externally or internally. External radiation is given by a trained medical specialist in a designated area of the hospital or clinic. Patients receiving external radiation therapy do not emit radioactive material. So your patient is not radioactive. So therefore, they do not require any safety precautions before or after the treatment. So your patient's going to lie down under this external radiation machine. And a lot of times it's called external beam radiation because you can see it kind of projects a beam from the machine. It's typically ordered around 5 days a week for about 1 to 10 weeks, and that's per the MD discretion based on the patient. The process takes about 15 to 30 minutes each time. Internal radiation is administered to patients admitted to a healthcare facility. It involves implanting radioactive material directly into the patient's body. Therefore, your patient is considered radioactive. So you have to follow specific safety guidelines when caring for these patients with an internal radioactive material. So those implanted radioactive materials are implanted into tissue or body cavities, or they could be administered orally or via IV route. Now, I want you to take note that internal radiation is not only these implanted radioactive materials in the body, but it's also considered oral radioactive drugs or IV route. Anything you're putting inside the body, the patient will be radioactive. So we'll talk about the safety measures in just a moment. But that radioactive implant is placed very close or inside the tumor so that it's an attempt to harm as few normal cells as possible. They want to get it as close to the cancerous tumor as possible. This allows your doctor to use a higher total dose of radiation to treat a smaller area and in a shorter time than it's possible with the external beam radiation on the previous slide. Your implants give off radiation for weeks to months. They can be temporary or permanent. You always want to teach your patient the reason why they're having these speedy nursing encounters. One of the safety measures is to limit your time in the room. So it's to limit your time and distance. We'll talk about that on a previous slide, but it's to limit the exposure of the nurse. So speedy nursing encounters and visitor restrictions, they're better accepted and less likely to promote feelings of isolation when they understand the reasons behind them. If you keep them informed, it also relieves a lot of anxiety as well. You can help prevent social isolation by bringing your patient some diversional activities that they enjoy. There are 3 primary factors to protect oneself from radiation. So these are your safety measures here that I want you to know. We're going to limit our time in the room, limit our distance, and shield ourselves. So we're going to be wearing a lead apron in the room to shield ourselves, limit our time in the room, and our distance. So this picture that I have on the slide, Nurse A is receiving the most radiation exposure, whereas Nurse B is receiving less radiation than Nurse A, and Nurse C receives less radiation than Nurse B. The nurses also wear a dosimeter badge in the patient's room that records the radiation exposure of that nurse. Also, you'll notice that they fluctuate with the patient assignment. So you're not going to have that patient all day. They want to fluctuate the nursing assignments so that not one nurse ends up with all the radiation exposure. So they take turns. The goal is to shorten the exposure risk. You have to work efficiently when caring for patients who are receiving radioisotopes. So those radioisotopes are talking about those internal radiation implants. Those release gamma rays, which are radioactive. Your exposure to radiation is proportionate to the time spent and the distance from the radiation source. So you will receive less exposure if you stand at the foot of the bed of a patient with a radioisotope inserted into the head than if you stand at the head of the bed. So if the patient has a radioisotope implanted inside their head, you're going to receive less exposure if you stand at the foot of the bed. So those principles of time and distance and shielding yourself with that lead apron and wearing that dosimeter badge, rotating our assignments, are all used to protect our nurses, our healthcare professionals, visitors. Radioactive waste cleanup. Always follow your hospital's policy. Never touch radioactive materials with unprotected hands. Always have gloves on. Never touch it with bare hands. If you're pregnant, you have no business giving an oral chemo drug or anything like that. When picking up a radioactive material, like let's say your patient has a radioisotope that was implanted and it somehow came dislodged. It got loose and came out. You're going to wear your PPE and use long-handled forceps and place it into a lead container. You always want to keep those supplies in every patient's room with their internal radioactive implant, just in case they become dislodged as a safety measure. Chemotherapy is a chemical therapy that uses cytotoxic drugs. These cytotoxic drugs are literally cell poison. So they're used to kill the cancerous cells. Chemotherapy works by keeping the cancer cells from growing, dividing, and making more cells. But because cancer cells usually grow and divide faster than normal cells, chemo has more of an effect on cancer cells. However, the drugs used for chemo are very powerful. they can still cause a lot of damage to healthy, normal cells. All that damage causes side effects that are linked with chemotherapy that we will discuss. Cytotoxic drugs or chemotherapy can be used to cure, control, or provide comfort, palliation of cancerous tumors. It can use to shrink the tumor, get it off those nerve endings so it's not causing so much nerve compression, causing pain. The side effects of your chemo are systemic, body system wide, unless they're used topically for skin lesions. Your chemotherapy affects the cell cycle and it stops division and growth of the cancer cell. Rapidly dividing cells like your hair, blood, skin, and GI tract are more susceptible because they are also fast-growing cells. Chemotherapy. So chemo is considered a systemic treatment because the drug travels throughout the body and it can kill cancer cells that have spread or metastasized to parts of the body far away from the original or primary tumor. It makes it different from treatments like surgery and radiation. Surgery removes a tumor from a part of the body where cancer has been found, and radiation therapy is aimed or beamed at a certain localized area of the body to kill or damage cancer cells. So surgery and radiation are more localized, whereas chemotherapy is more systemic. So one thing to note is that not all chemotherapy drugs work the same way. And in this chapter, they cover various different types that we will talk about. Chemotherapy can be given in various routes. It can be given orally, like you can take the chemo drug by mouth. Take note that you don't want to touch the pill with your bare hands. You must have gloves on. Nobody pregnant giving the medication, things like that. It's normally locked up. So it can be a pill, a capsule, or a liquid. So oral treatments for cancer are now more common these days. And some of the drugs are given daily, whereas others are given less often. You also have your IV chemotherapy. So that requires injection directly into the vein. And, you know, it just depends on what type of chemo it is, but some of the IV chemos work better if you give them over a few days or weeks. You also have topical chemotherapy that you just apply topically to your skin. You put the cream right on your skin. You can get your medication at the pharmacy and take it home. And then you have combination therapy. So in this type of therapy, 2 or more anti-neoplastic, meaning anti-cancer agents, are used together. This can expose a larger number of cells at different points in the cell cycle. So if you combine different chemotherapy drugs, because there's so many different types, they affect the cancer cells at different parts of the cell cycle, so it makes it more effective. It's exposing a larger number of cells at different points in their cell cycle to chemotherapy. Combining the drugs is also good because it is known to decrease the side effects of therapy, and it also decreases the possibility of the tumor becoming resistant to any one therapy. For drugs to be combined, several criteria has to be met. So each drug must be effective when used alone to treat the cancer. Each must have a different toxicity that would limit its use. For example, if 3 drugs that are all toxic to the heart, they're cardiotoxic, the patient is more likely to to develop cardiotoxicity. Patients are still monitored for toxic effects from the treatment as well as improvement in their status. So they wouldn't want to pick three chemo drugs that are all cardiotoxic. They would want to pick ones with different toxicity so the patient is less prone to develop toxicity of the heart. When we mentioned IV chemotherapy, chemotherapy is a very vesicant drug, meaning it's very hard on the veins. Vesicant drugs are given only by the IV route into a large vein. Your vesicant drugs, so they're only given IV route into a large vein. And these drugs can cause blistering of the tissue. Eventually, it could lead to necrosis if they infiltrate or leak out of the blood vessel and into the soft tissue and the skin around it. So if necrotic tissue occurs, skin grafts may be needed if the tissue damage is very extensive. So anytime you see an infiltration noted, you're going to stop the infusion right away and notify the RN and the MD. And this is if you see a vesicant like chemotherapy drug infiltrating. If the vesicant chemo drug drips on the floor, so it accidentally drips or spills on the floor, you're going to use your PPE, your gloves, gown, and you want to follow your agency policy for cleaning up that spill. Oral chemotherapy drugs can be just as potent as IV route. Some agents are given concurrently with either IV chemo or radiation. You always want to handle it with gloves. They should never be stored with other medications. And you never want to crush or break any oral chemo agents. Side effects of chemo. So toxicities in patients receiving chemo vary with the medications given. But there are some general side effects common to chemo drugs because they affect all rapidly growing cells. Chemo cells are very rapidly growing itself, but the chemo can't differentiate between what's a cancer cell and what's a fast-growing hair cell or a cell in the GI tract or the skin or the blood. So chemo drugs attack all rapidly growing cells. So your fast-growing epithelial cells like those of the hair, the blood, the skin, and the GI tract are usually the most affected by chemotherapy and radiation. Chemotherapy is very toxic to bone marrow, so that is where blood cells are produced. Your number of blood cells, particularly your white blood cells, drop after approximately 7 to 14 days of chemotherapy. It's depending on the type of chemo drug, of course. So the period in which your blood cell counts are at its lowest point is called nadir. So it's bone marrow depression at nadir. So it is the period at nadir that causes a lot of these side effects that are associated with chemotherapy, such as the leukopenia, which is your low white blood cell count. Leukopenia is sometimes referred to as neutropenia because the neutrophils are the most plentiful of the white blood cells. So this is where the patients are at a very high risk for infection. Hand washing is essential. Also, you have your thrombocytopenia, which is your low platelets. So, of course, your platelets help with blood clotting. So when they're low, you're worried about bleeding. They're at an increased risk for bleeding. Watch for bleeding, hemorrhage, tarry stools, nosebleeds, things like that. You have an increased risk of anemia because of the reduction in the red blood cells. So the patients may require blood transfusions. So chemo attacks the GI system as well because the lining of the GI tract is made up of rapidly dividing cells. It's very susceptible to the toxicity of chemo drugs. So patients often experience nausea, vomiting, diarrhea. You also see an inflammation of the mouth. It's called stomatitis. Your hair is also a rapidly dividing cell. So chemo attacks your hair, causing alopecia or hair loss. It's common with many, but not all chemotherapeutic drugs. And it's a temporary condition. Growth of the new hair starts when the chemotherapeutic medication is stopped. Alopecia involves the entire body, so it includes your eyebrows, eyelashes, axillary and pubic hair as well. Hair that regrows may be a different color or texture than the original hair. Reproductive system is also affected by chemotherapy or radiation. It can cause permanent or temporary changes in the reproductive system. Chemo can actually damage sperm and ova, the egg. You have issues concerning fertility that should be discussed with the patient prior to treatment. So they have options like possibly freezing their ova or their eggs or using a sperm bank prior to starting their chemo treatments. That provides your patient some options if they do want kids in the future. Patients should also talk to their healthcare providers before engaging in intercourse during chemo and use protection against pregnancy. The neurosystem is also affected by chemo. An adverse reaction to a medication called Oncoven is neurotoxicity. So it can cause tingling and numbness in the extremities. It can cause foot drop in severe cases for muscle weakness. Less commonly, you'll see complications including renal toxicities, like pain and burning on urination or blood in the urine. There's a medication we're going to talk about on one of the tables in this chapter. It's called doxorubicin or adriamycin. That's associated with permanent heart damage. Bleomycin can cause pulmonary fibrosis. So you can see that different chemo drugs have different toxicities to different areas of the body. There's a mnemonic that you can use to remember the side effects of chemo and radiation, and it's called BITES. B for bleeding, suggesting a low platelet count. So when you're thinking of that risk for bleeding, you're thinking of low platelets. I for infection, suggesting that low WBC count. T for tiredness, suggesting anemia or that low red blood cell count. E for emesis, due to the chemo or radiation attacking that GI tract. Risk for altered nutrition, fluid electrolyte imbalance. There's a lot of nausea and vomiting involved. S for skin changes, suggesting radiation reaction like desquamation or skin breakdown because the chemo and the radiation also attack the skin. Chemotherapy extravasation. So extravasation is a leakage of fluid. So it's referring to the leakage of a vesicant, something that's very irritating, like chemotherapy. It can lead to blisters, tissue necrosis, injury. So if this happens, you need to alert the doctor right away and stop the infusion immediately. Colony stimulating factors. So these are medications that aid in proliferating different types of blood cells. Each one has a different action. These are listed in table 11.5 on page 155. The first one is granulocyte colony stimulating factor. So these stimulates proliferation of stem cells into neutrophils. So it increases the neutrophils. It increases neutrophils. The two most common ones that I want you to know are Neupogen and Neulasta. And those are pretty easy to remember that they increase neutrophils because neutrophils starts with NEU, as does Neupogen and Neulasta. The next one is granulocyte macrophage colony stimulating factor. This stimulates proliferation of all the different types of white blood cells, your neutrophils, monocytes, macrophages, and eosinophils. Remember, never let monkeys eat bananas, the different types of white blood cells. So white blood cells are called leukocytes. So all the different types of white blood cells listed here. Leukine, leukocytes. Leukocyte. It's hard to write on this, I apologize. The next one is erythropoietin. So erythropoietin, remember, is in the bone marrow, and it stimulates the production of red blood cells in the bone marrow. That's exactly the action that this has. So red blood cells, we have epigen and aranesp. Some of the nursing implications for these drugs is that they have a black box warning for heart disease risk. They're very hard on the heart. You want to monitor the blood pressure and the hematocrit because you have a risk for very high blood pressure and for a high hematocrit because this drug is going to increase the red blood cells. They give these to dialysis patients as well. You might have seen them for some of your patients on dialysis that are going through anemia. The next medication we're going to talk about is Numega, and that stimulates production of platelets. So all of these drugs are in the drug class called colony stimulating factors. So this is the drug class right here. So you see each one has its own action. So these are drugs that are fair game for your test here. You've got epigen. Also, there is, it's also called Procrit, you might see. Let me write that on here. It's in your book on page 155. Leucine, Neupogen, and Neulasta. Just understand what they increase. So with this oncology chapter, chapter 11, it contains a lot of medications in it. So I'm trying to pinpoint you which medications to hone in on for your exam. On table 11.6 on page 157 of your textbook, you'll see this medication right here. It's called adriamycin, and it's actually an anti-tumor antibiotic. So it works by damaging the cancer cell's DNA and the cancer cell's ability to make DNA and RNA. So it affects the cancer cell's ability to replicate itself. So this first medication, it's called doxorubicin or adriamycin. It's on the very top of table 11.6. The thing to note about that is it attacks rapidly dividing cells by damaging the DNA. It turns the urine a red color. That's something to note because you would definitely want to teach your patient that. Teach them that it's not blood in their urine, it's just the medication's effects. That's completely normal for this drug, so you have to make sure you teach your patients, otherwise they'll be very alarmed. It attacks your hair cells. Of course, it's a rapidly dividing cell, so it is known to cause alopecia as a side effect or hair loss. This medication, adriamycin, is known to cause cardiotoxicity, so it's toxic to the heart. So one thing you want to do before administering adriamycin for the first time is you want to obtain a baseline EKG before administering the medication. So you want to monitor your cardiac status of your patient. The next medication here is paclitaxel. Paclitaxel here, this medication is found on, let me write the page number right here. It is page 158. Excuse my handwriting on this computer, y'all. Do the best I can. So paclitaxel, this is an antimitotic agent, and it is preventing mitosis from occurring. So it makes the cancer cells unable to divide. This medication is known for causing low platelet counts. So the patient is at risk for bleeding. You want to monitor their CBC and platelet counts. And I want you to remember this right here, that the patient is at risk for bleeding when the platelet count is 50,000, and there's an increased risk for spontaneous bleeding when the platelet count is less than 20,000. This information about the platelet counts that I have here is from page 161, and it's under the data collection paragraph towards the bottom of the page on the left-hand side. Your next medication is your epoetin alpha or your Procrit. Procrit is on that table on page 155. And so it is given to stimulate production of red blood cells. It is used to treat anemia. So it's going to increase your red blood cell count. It comes with a black box warning for heart disease risk, and a black box warning is like the highest warning. You're really concerned about the patient's heart disease risk because you're adding a lot of extra blood volume here. So like heart failure patients, things like that, it'd be very dangerous. You want to monitor for your heart status, monitor their blood pressure, their hematocrit very closely, because it will be known to elevate both of those things. It would elevate the blood pressure and elevate the hematocrit. So your hypertension is going to be a common side effect of your procrit. Alkylating agents. So these can be found on page 157 of your Med Surg book. It's table 11.6. Also, you can look in your pharmacology book on page 335. There's some information about it as well. So your alkylating agents is one of the oldest categories of your anti-neoplastic medications. They help prevent reproduction of the cancer cells. They're effective during all phases of the cell cycle. So that's really good. It's really effective. It's an effective medication because it's not limited to any one point in the cell cycle. It's actually effective during all phases. It's really ideal for treating leukemia. Your blood and bone marrow cells are particularly sensitive to these alkylating agents. However, there's a major side effect here of bone marrow suppression. So you want to make sure you check the CBC prior to each dose. So you're looking for all those low counts, low white blood cells, low red blood cells, low platelets, things like that. The examples here, I bolded the ones that are the most likely to see again. You got your leukerin and your cytoxin. These are both alkylating agents. So with them, you want to make sure you're assessing for bone marrow suppression. Anti-metabolite medications. These are also found on page 157 of your book. So they gain entry into the cancer cells and they impair the cell division. They're used in metastatic breast, colon, or rectal cancers, GI tumors, sometimes used to treat cases of leukemia. One that you see most often is called methotrexate, and it actually wasn't in your Med Surg book. I found it in your pharmacology book on page 335. That's one you see more often, so I wrote that in my book under the anti-metabolite section. I just wrote in methotrexate. It's also known as Trexol. So with these medications, you want to check your CBCs before each dose for bone marrow suppression as well. Review the signs of infection or bleeding. Instruct the patient to call the primary health provider for any temperature increases greater than 100 degrees Fahrenheit. Check CBC before the dose. You can also pre-medicate the patient with antiemetics. They're also known to cause some nausea. So you can see I have bolded all these medications that are fair game for your exam here. So I'm kind of pinpointing you in the right direction, which medications to focus on. The anti-tumor antibiotics, we've discussed on a previous slide that they damage the cell's DNA and the ability to make DNA and RNA. So it makes the cancer cells less likely to be able to divide because they're attacking their ability to make the genetic material. It's actually created from bacteria found in soil, and they're used to create these antibiotics that are used to kill cancer cells. So the one I want you to remember here is the adriamycin that we mentioned on the previous slide. Just remember, it turns the urine red, and make sure you teach your patient about that. Otherwise, it's very alarming, very scary for them. It's not blood in their urine, it's just the medication causing the color change. It is known to cause alopecia because it does attack rapidly dividing cells, and not just cancer cells, also the rapidly dividing normal cells in our body, like our hair. It does cause cardiotoxicity, so you want to obtain a baseline EKG, check out their cardiac status before administering the medication. The antimitotic agents we also discussed on a previous slide. So they also affect mitosis, that ability for the cancer cells to divide. It's used to treat lots of different cancers, as you can see. And the example I want you to remember is paclitaxel. It's the antimitotic agent. So it prevents mitosis from occurring. Monitor CBC and platelet counts, because it is known to lower your blood counts. Your patient is at risk for bleeding when the platelet count is 50,000. A risk for spontaneous bleeding occurs when your platelet count is less than 20,000. And that's found on page 161 of your Med-Surg book. And you will need to know that right there. You will need to know those lab values. I made you a quick little outline here of the important anti-cancer medications to know for your upcoming exam. Just anything I specifically pinpointed out in this lecture, anything in your Med-Surg book is fair game. And I want to make sure to emphasize that these care plans in the back of each chapter in this Med-Surg book are super important. A lot of times they contain information that's really important. They hide some important stuff in here. So make sure you're reading through these as you're studying. Use this as a study tool. This first care plan on page 162 is ineffective coping, and that is huge for cancer. You know, related to the diagnosis of cancer, maybe it's a new diagnosis for them, or the treatment of cancer, coping with, you know, the harsh treatments of chemotherapy and radiation. So you want to do your best to assess the coping mechanisms of your patient. So what kind of coping mechanisms has he or she used in the past, and were they effective? So coping mechanisms that have worked in the past may be helpful again. The nurse can support those appropriate choices, so you can help them identify those. Use your active listening skills to encourage your patient to express feelings and their fears. So in order to cope with their fears, they must first identify them. Assess the meaning and quality of life to your patient. Once they identify that, the nurse can assist the patient to achieve quality of life goals. Assess for any suicidal risks. A patient who feels hopeless may be at risk for suicide, so you do want to include that with your assessment. Explore outlets that promote feelings of personal achievement. So does the patient have some sort of creative outlets that promote feelings of achievement? Some sort of hobby or anything like that? So personal achievement promotes self-esteem in your patient, and it will ultimately help with their coping. Consider the use of humor appropriately, of course. You kind of have to read the room. Humor can be both distracting and therapeutic. So if you feel like your patient is one that has a sense of humor that would be more open to that, that's fine. But humor is not always appropriate to use. You kind of have to read the room, use your nursing judgment there the best you can. Does the patient themselves use humor? Does it provide a temporary distraction from concerns? In many patients, it does, but not everybody might like the use of humor. So you kind of have to gauge, the appropriateness of it. The next nursing diagnosis is acute or chronic pain. So you want to assess their pain. Assessment provides direction for the treatment plan. Have them rate their pain on a scale. Administer your analgesics as ordered around the clock. If you use an around the clock, like scheduled pain medication, it prevents pain from becoming severe. So if the pain gets at like a level 10, for example, it's harder for it to come back down than if we treat it while it's at a level 5 or 4 per se. So a lot of times these cancer patients will not only have as needed pain medications, but they might be on around the clock, like scheduled pain medications that they get on their medication administration record. Check your pain relief within 1 hour of administration of the medication, and then every 2 to 4 hours. You may have to give some short-acting medications for breakthrough pain, like IV morphine or Dilaudid, whatever kind of medication that physician has prescribed for them on a PRN as needed basis. So they're likely to have scheduled medications and then PRN meds for breakthrough pain. Educate the patient on the use of a patient-controlled analgesia pump. That's a PCA pump where they press the button to administer the dose. A lot of cancer medications have this ordered. It's not always used, but it is an option for pain relief for them, so you might see it. Patients who receive long-term opioid therapy, just take note, may develop a tolerance to depressant effects of opioids. Always assess their respiratory rate. Is it between 12 and 20? Monitor their sedation level and respiratory status if opioid dose is increased. So they may require increasing doses of their opioid medications. There's also non-pharmacological interventions like relaxation or guided imagery once the pain is controlled with medication. Risk for infection is another nursing diagnosis, which is huge for our cancer patients because they are on all these medications that depress their immune system due to that bone marrow suppression. So it's due to diminished immunity and bone marrow suppression as a result of chemo or radiation. Chemo and radiation can cause bone marrow suppression. So teach those good hand hygiene techniques. That's a perfect place to start with your patient teaching. Monitor their body temp every 4 hours or per protocol, like per your orders. However often your doctor wants you to check their vitals, that's what you're going to do. Monitor their white blood cell count and their CBC daily for the signs of bone marrow suppression. Assess for signs of inflammation or drainage at a potential infection site, like an old aspiration site or a lesion, incision, things like that. So check their skin very good. Watch for signs of respiratory infection, like shortness of breath and cough and sore throat, sputum. Assess for signs of a UTI, like burning, pain, urgency, or blood in the urine. Teach the administration of their medications, your colony stimulating factor medications. They help the body produce more white blood cells. And the patient may need to administer it subcutaneously at home. So it's possible they may need to give those colony stimulating factors at home. And we talked about that previously in the chapter. They were located on page 155 if you want to review them again. So some examples were like your Neupogen and your Neulasta. So they help produce more white blood cells. So it's helping to counteract that bone marrow suppression. Limit your visitors to only healthy adults. You don't want anybody coming in contact with them that has a cold. Teach your patient to ask healthcare provider about avoiding unwashed fruits and vegetables. So these patients need to avoid things that are unwashed. They want to avoid unpeeled fruits and veggies. No fresh flowers. Imbalanced nutrition is also important for your cancer patients. You want to monitor their weight daily. And weight is the most objective measure that you can do to determine if their intake is adequate enough to maintain their weight. So weight is the most objective thing that you have. Is their intake meeting their requirements to maintain their weight? Of course, they're going to have a dietitian on board. Monitor their intake and output. Administer your meds, your antiemetic meds, like nausea, vomiting. You can offer sour foods like lemons, mouth care before meals, pain medications before meals. Remember to provide small, frequent, high-calorie meals. And a good insight into a patient's nutrition level is their albumin level. Albumin level less than 3 indicates poor nutrition, and I do want you to remember that lab value for your upcoming exam. So albumin's a type of protein. So it really gives good insight whether the patient is malnourished. So if it's less than 3 grams per deciliter, it indicates poor nutrition. A survivorship plan is a record of your cancer and treatment history, as well as any checkups or follow-up tests you may need in the future. It also lists any possible long-term effects of your treatments and ideas for staying healthy. Continued reassessment of a patient's needs and the creation of this survivorship plan are essential to maintaining a positive outcome for your patients. You can help your patients and families find local survivorship programs for needed assistance and counseling. Our chapter 17 in the oncology section is really where we're going to discuss hospice care more in detail. But hospice care needs a less than 6-month prognosis. So we're going to put a pin in this for right now for this chapter, and we will continue the discussion about it in chapter 17. Oncological emergencies. Superior vena cava syndrome. This occurs in patients with lung cancer or cancers of the mediastinum, where the tumor or an enlarged lymph node blocks the circulation in the superior vena cava. It's resulting in edema of the head, neck, and arms. Your symptoms include shortness of breath, cough, chest pain, facial redness, and swollen neck veins, so positive JVD. Nursing interventions for the patient with superior vena cava syndrome include removing rings and restrictive clothing due to all that edema. Avoid taking blood pressures and venipunctures in the arms, and elevating the head of the bed to decrease feelings of dyspnea. Spinal cord compression. So this occurs when a malignant growth compresses on the spinal cord. It's a painful problem that requires pain management while radiation is given to relieve the symptoms. Patients may develop some motor loss when this occurs. Nursing care includes providing a safe environment, assisting with activity, and watching for changes in neurological status, as well as changes in the location and intensity of pain. Patients at risk for a spinal cord compression include those with cancers that spread to the bone and the spinal cord, such as the lung, breast, and prostate cancer. Another complication that could occur is hypercalcemia. This is a serum calcium level that exceeds 11 milligrams per deciliter. Hypercalcemia can result from the release of calcium into the blood from bone breakdown, from the breakdown when it metastasizes into the bone. It starts to break down and it releases the calcium from the bone into the bloodstream. So you have a high level of calcium in the blood with metastasis. The serum calcium exceeds 11 milligrams per deciliter, and I have a little memory jogger that I use just to help me remember calcium. So your normal calcium level is 8.9 to 10.1, and remember, normal lab values do differ from textbook to textbook, but they're all pretty well in range of each other. They may just be slightly different here and there. So I remember it by the weather in California. California starts with Ca, like calcium. The weather in California is between 89 and 101 degrees. So calcium 8.9 to 10.1, normal range. All of these lab values that I've listed here are fair game for your upcoming exam, so make sure you study them. Your normal calcium level, which we just talked about, 8.9 to 10.1. We just said the memory jogger on the previous slide. Your normal potassium level of 3.5 to 5. My memory jogger is when you buy bananas, they usually come in a bunch that contains 3 to 5 bananas, and you want to buy them when they are half ripe. So hence it's 3.5 to 5 is the normal range. Your normal albumin level, 3.5 to 5. Memory jogger, can I bum albumin? $3.50 or to $5 off of you to buy lunch. Normal white blood cell count is 4,500 to 11,000. I don't have a silly memory jogger for that one, but if you do think of one, please send it to me. I would love to add it. Normal platelet count is 150,000 to 450,000. My memory jogger, our fancy plates, can cost upwards to $150 to $450. We're talking about fine china here. Our normal hemoglobin count. So our hemoglobin, I like to remember lab values in whole numbers to make it easier to remember rather than decimals. And that's a good example of the hemoglobin. I like to think of puberty. So females mature faster than males, around 12 to 16 years of age, which is your normal female hemoglobin, 12 to 16. Males mature a bit later, at around 14 to 18 years of age. Normal male hemoglobin is 14 to 18. So some labs differentiate between what's normal for females and what's normal for males, such as the hemoglobin. So make sure you study these lab values. Which test is essential to the diagnosis of cancer? And this one's pretty simple here. You should have gotten biopsy. Which principles are essential for maintaining safety when working with patients with radioactive implants? So remember, when there's a radioactive implant, your patient is considered radioactive. So you have to take certain precautions into place. The answer will be on the next slide. So if you need to pause the slideshow to read through the question, feel free. The answer was you need to limit your time, limit your distance from the patient, and shield yourself. You're going to wear that lead apron. Which interventions are appropriate for a patient with thrombocytopenia? So thrombocytopenia, which lab is that talking about? Take a moment to look at this question. You can pause the slideshow if you need to, and the answer will be on the next slide for you. So thrombocytopenia is talking about low platelets. Low platelets. So we want to protect from injury because they're at a very high risk for bleeding. And we want to report bruising or bleeding. You're also going to look for things like tarry stools, any signs of internal bleeding. Which patient is appropriate for hospice care? The answer will be on the next slide. The answer is a patient with kidney disease who has 3 months to live. So with hospice, you need a 6 months prognosis. 6 months or less are eligible for hospice care. We will discuss this more in Chapter 17.